Assalamu alaikum everyone, and welcome to the very first episode of Dr. Watches. My name is Mariam Athar and I am an associate in the events department at Sign. I'll be hosting this session today alongside my co-host Simra Farhan. Simra, over to you.
Assalamu alaikum everybody. My name is Dr. Cerebral Farhan. I'm a graduate from Dow Medical College, class of 2025. Today I'll be your host for the first half of this session. In this series, we will analyze medical cases from popular TV shows and compare them with real-world medicine. We today looking at a pilot episode of House MD featuring a patient who presents with progressive neurological symptoms and is ultimately diagnosed with neurocysticercosis. Throughout the session, we'll discuss how realistic the presentation was, what were the differential diagnoses, whether House's reasoning made any sense, or how this patient would actually be investigated and treated today. Before we begin this session, I'd like to introduce our guest speaker for today's session. We are delighted to have Dr. Arbab with us, who is an accomplished neurologist with an extensive experience in the diagnosis and management of neurological disorders. His clinical expertise and passion for medical education makes him the perfect person to help us analyze today's fascinating case of neurocysticercosis and compares the show's portrayal with real world neurology practice. Thank you, Dr. Arbab, for joining us today.
Thank you. Thank you for having me.
Okay, so we'll start with the first clip. Can we have the first clip, Hafsa? Okay, so as we saw in this clip, the patient suddenly develops difficulty speaking while teaching and then collapses. So my first question to you, Dr. Arbab, is to start, what is your immediate impression of this presentation?
Yeah. So this brings back so many great memories from medical school. So my immediate impression is that this is an acute focal neurological event, most concerning for a stroke. The key feature being sudden onset of difficulty speaking while otherwise functioning normally, followed by collapse. In neurology, sudden focal deficits are vascular until proven otherwise. And aphasia localizes to the dominant hemisphere, typically the left cerebral hemisphere in most individuals. So my first concern will be an acute cerebral vascular event affecting that region.
Oh, that's a really nice answer. Okay, so and if the patient arrived at the ER with this exact presentation, what would be the first few differentials that you would think about? Would neurocysticercosis even come into your mind at this point?
No, not. This won't be my first diagnosis. So my differential will be led by acute ischemic stroke, followed by intracerebral hemorrhages, seizure with postictal neurological deficit, less commonly a brain lesion presenting with a seizure or hemorrhage into a lesion. I will also consider any metabolic stroke mimics such as hypoglycemia, although the focal language deficit makes a structural neurological process more likely.
Oh, that's an insightful answer. Thank you. Okay, so can we have the next clip, Hafsa? Okay, so in this it's a picture that we can see a CT lesion. So when neurologists see a solitary brain lesion, what broad categories do immediately come in mind, Dr. Arbab?
So when you see a solitary lesion on a CT scan, the first step is to think broadly rather than to jump to a specific diagnosis. The major categories I consider are neoplastic, infectious, vascular, inflammatory, and less common congenital or traumatic lesions. From a practical standpoint, the leading consideration for a solitary lesion will include a primary brain tumor, a metastatic lesion, a brain abscess, and certain parasitic infections such as neurocysticercosis, depending on the patient's epidemiological background. I would also consider vascular lesions such as a resolving hemorrhage, an inflammatory condition that can occasionally appear as a focal lesion on imaging. At this stage, the lesion is a clue, but it is not yet a diagnosis. The patient clinical presentation, imaging characteristics, laboratory data, and exposure history all have to be integrated before we can determine the cause.
So just looking at this, we can't really say that it's neurocysticercosis, right?
No. So we just can't jump to conclusions at this point.
Yeah. Okay, definitely. Next link, next video, please. Okay, as we saw in this clip, that House notices an elevated ESR and begins considering cerebral vasculitis. So how useful is ESR in diagnosing cerebral vasculitis, Dr. Abad?
So, ESR can be a helpful piece of information, but it is a very non-specific marker of inflammation. And elevated ESR tells us that there's some inflammatory process that may be occurring in the body, but it does not tell us what the process is or where it is located. In the context of suspected cerebral vasculitis, an elevated ESR might support the possibility of an inflammatory condition, but is far from diagnostic. Many disorders can elevate the ESR, including infections, autoimmune diseases, malignancies, and even some chronic medical conditions. In fact, some patients with cerebral vasculitis may only have modest elevation and even normal inflammatory markers. So, as a neurologist, I will never diagnose cerebral vasculitis based on elevated ESR alone. The diagnosis typically requires a combination of clinical findings, neuroimaging, vascular imaging, laboratory studies, and sometimes tissue biopsy as well.
That's a really nice framework. Have the next clip, please.
So in this clip, House suggests stopping treatment and simply observing the speed of deterioration because different diseases kill at different rates, right? So has there ever been any role for this approach in modern medicine?
So, historically, before the advent of modern neuroimaging, advanced laboratory testing, and contemporary critical care, physicians sometimes relied heavily on the natural progression of the disease to help clarify a diagnosis. However, in modern medicine, intentionally withholding diagnostic evaluation or treatment simply to observe how quickly a patient deteriorates would not be considered an acceptable diagnostic strategy. Disease progression can certainly provide diagnostic clues, and neurologists do pay attention to the tempo of the illness, whether symptoms evolve over seconds, days, weeks, or months. The rate of progression often helps us distinguish between vascular, infectious, and other processes, but the information is gathered while we are actively investigating and managing the patient, not by standing back and waiting for the disease to declare itself. In other words, the pace of deterioration informs the diagnosis, but is not a substitute for diagnostic evaluation.
Okay. Thank you for this insight. Furthermore, I would like to ask that even though this looks good on television, but in reality, would neurologists continue aggressively investigating rather than waiting?
Oh, absolutely. A patient with fluctuating mental status, vision loss, cardiac arrest is critically ill and demonstrating evidence of a potentially evolving neurological process. In that situation, the priority will be to rapidly determine the underlying cause while simultaneously stabilizing the patient. As a neurologist, we will be pursuing additional imaging, reassessing the neurological examination, reviewing the laboratory data, considering infections, inflammatory causes, vascular neoplastic causes, coordinating closely with the critical care and other specialists. If diagnosis remains unclear, we will typically escalate the investigation rather than to pause it.
Oh, okay. Thank you for explaining it so well. Hafsa, so we will move on to part 5 and 6 of the case. Can you please play it? We see that Dr. House starts connecting the diagnosis to pork consumption and suggests neurocysticercosis. So, Dr. Arbab, for our audience, could you tell us what neurocysticercosis actually is and how does it develop?
So, neurocysticercosis is an infection of the central nervous system caused by the larval form of the pork tapeworm Taenia solium. It is the most common parasitic infection of the brain worldwide and a major cause of acquired epilepsy in many parts of the world. One important point is that people do not typically develop neurocysticercosis simply by eating pork. Eating undercooked pork can lead to an intestinal tapeworm infection known as teniasis, and neurocysticercosis occurs when a person ingests tapeworm eggs, usually through the fecal oral transmission. The eggs hatch, the larvae enter the bloodstreams, and then they lodge into tissues throughout the body, including the brain, where they develop into cysticerci. Once in the nervous system, these cysts can remain relatively silent for years, sometimes arise either because of their location in the brain or more commonly because of the inflammatory response that develops as the cyst begins to degenerate.
Okay, that was a really great overview. Thank you for breaking that down for us. Dr. Arba, my next question would be that in the later scene, we also see that the patient improved with the steroids, but worsened when the parasite began dying. Can you explain what happens when cysticerci degenerate?
So the concept is actually grounded in real pathophysiology. Viable cysticerci are often surprisingly good at evading the host immune system. While alive, they can suppress the local inflammatory response, allowing them to persist in the brain with relatively little surrounding reaction. Problems often begin when the parasite starts to degenerate, either naturally or as a result of an antiparasitic therapy. As the cysts break down, parasitic antigens are released and become visible to the immune system. This triggers a robust inflammatory response involving immune cells, cytokines, and disruption of the blood-brain barrier. Clinically, that inflammation can produce cerebral edema, worsening headaches, seizures, focal neurological deficits, increased intracranial pressure, and changes in mental status. In some patients, symptoms actually become more pronounced during that period when the parasite is dying because of the inflammatory response, rather than the parasite itself is responsible for much of the neurological injury.
That's really fascinating. And I think it adds a lot of context to what we just saw in the clips. Thank you, Dr. Arbab, for explaining it so well. Let's move on to the seventh part of our episode. Hafsa, can you please play the clip? Okay. So in this scene, Dr. House suggests looking for evidence of worm in the thigh muscle. Dr. Arbab, can you tell us how realistic is this, and can cysticerci occur outside CNS?
So, from a neurologist perspective, the idea is actually more plausible than it may sound. Neurocysticercosis is part of a systemic infection, and the larva can disseminate to multiple tissues throughout the body. Skeletal muscle is one of the most common extracranial locations where cysticerci can be found. So, common extracranial sites include skeletal muscle, subcutaneous tissue, and even the eye. Muscle involvement is often asymptomatic and can only be discovered incidentally. Subcutaneous cyst can sometimes present as small palpable nodules beneath the skin. Ocular cysticercosis is particularly important because it can threaten vision and may require specialized treatment. In some patients, the infection is limited to the nervous system, while in other parts of the more widespread disseminated process can be found. So, finding cysticerci outside the brain can be diagnostically helpful because it strengthens the evidence of the intracranial lesions are due to the cysticercosis.
Okay, that's a really great point. Dr. Arbab, moving forward, I would also like to ask that would a muscle X-ray still have any role in modern diagnostics?
So the thing is, just like I said, if you have brain lesions, you have something in mind that if you come to a point where you're thinking about neurocysticercosis, you can go definitely look up for other cysts as well. Normally, it's a very incidental finding, and it will only show up on X-rays when it has calcified. The cyst has calcified. Sometimes it may not even show up. So definitely, if you're thinking about neurocysticercosis, you have come to a point where you feel like neurocysticercosis can be the cause of the symptoms. You can definitely go and look for some other cyst in the body, and skeletal muscle being one of them.
Okay, that's perfect. Thank you for that explanation. Hafsa, let's move on to the eighth and final clip from today's episode. So, as we see in the clip that the patient is started on albendazole. So, Dr. Arbab, can you tell us if albendazole is still the standard therapy for neurocysticercosis, and is it sufficient alone?
So albendazole remains one of the standard treatments for neurocysticercosis and is still widely used today. However, whether albendazole alone is sufficient depends on the specific clinical scenario. Modern management is individualized based on the number, location, and stages of the cyst. For some patient with a limited number of viable parenchymal cysts, albendazole may be an appropriate antiparasitic agent. In other cases, particularly when there are multiple visible lesions, combining therapy with albendazole and other antiparasitic medications may be considered. Equally important is that treatment is just not about killing the parasite. Many patients also require corticosteroids to control inflammation, like I said before, and anti-seizure medications as well if seizure have occurred. So as a neurologist, we think of treatment as a comprehensive strategy rather than simply prescribing an antiparasitic drug.
Okay, I think our audience will find that especially valuable. Thank you for explaining it so clearly. Further on, I want to ask if there are any certain situations or conditions in which treating the parasite can actually be harmful.
So, this is one of the most important concepts in neurocysticercosis management. The major concern is that when antiparasitic therapy kills the cysticerci, the resulting inflammatory response can temporarily worsen the patient condition. As the parasite degenerates, they release antigens that trigger inflammation, causing cerebral edema and increased intracranial pressure. This can lead to worsening headache, seizures, focal neurological deficits, or changes in mental status. In some situations, the inflammatory response or reaction can be more dangerous than the parasite itself. So that reason, treatment decisions must be individualized. There are circumstances in which immediate antiparasitic therapy may be deferred, modified, or accompanied by aggressive anti-inflammatory treatment. The location of the cyst is particularly important. For example, lesions in critical areas of the nervous system or those associated with obstructive hydrocephalus can pose special risk when inflammation develops. So we really need to be careful at that.
Okay. Thank you for sharing that insight. As now we are done with our clips for this episode, and we have spent a lot of time discussing the specifics of this case, I'd like to broaden the discussion a bit and focus on some of the challenges that physicians may face treating this condition in real life scenarios. So, throughout our discussion, we have talked about MRI findings, serological testing, and specialist evaluations, which no doubt are all important tools in diagnosing neurocysticercosis. However, these resources may not always be readily available, particularly in resource limited settings. So, Dr. Arbab, my question would be that if this patient presented to a hospital in a low or middle income country with limited access to advanced imaging and specialized testing, how would your diagnostic approach change?
So the overall diagnostic framework will remain the same, but I will rely much more heavily on the clinical history, neurological examination, epidemiological context, and the basic imaging findings. In many parts of the world where neurocysticercosis is common, clinicians become very skilled at recognizing characteristic presentations. If a patient presents with new onset seizures, focal neurological deficits, or headaches, and if a CT scan is available, CT scan will reveal multiple compatible lesions. Neurocysticercosis may rise much higher on differential diagnosis than it will on in a non-endemic setting. So ideally, we will obtain an MRI if available, serological testing, specialist consultations. But when those resources are unavailable, diagnosis often becomes a synthesis of available evidence rather than a single definitive test. The physician has to balance diagnostic certainty against the need to make timely treatment decisions. Important is that the limited resources does not mean lower quality clinical reasoning. In many resource constrained settings, clinicians manage neurocysticercosis routinely and may recognize it more quickly than physicians practicing in regions where the disease is rarely encountered.
That's a very interesting explanation, and it surely gives us a much better understanding of how to treat such patients in resource limited settings. Another question I have is that what were the biggest misconceptions viewer might have taken away from this episode?
So, the biggest misconception is probably that diagnosing rare neurological disease is primarily a matter of one brilliant physician making intuitive leaps. I think this is a bit far fetched. In reality, diagnosis is usually a structured process involving history taking, neurological examination, imaging, laboratory studies, consultation among specialists, and continual reassessment of the competing possibilities. Another misconception is the suggestion that physician might intentionally withhold evaluation or treatment simply to observe the disease progression. While disease tempo is diagnostically important, modern neurological practice emphasizes active investigation rather than passive observation. The episode also somewhat oversimplifies the relationship between pork consumption and neurocysticercosis. Viewers may leave the impression that eating pork directly causes brain cysts, when in fact neurocysticercosis results from ingesting tapeworm eggs through fecal oral transmission.
Okay. Those are really great points. Thank you for explaining these misconceptions to us. Further on, I'd like to ask, how would you rate this episode's medical accuracy out of 10?
As a fan, 10 out of 10, but if you're asking me as a neurologist, then I'll give it a 7.5 out of 10. So the writers do deserve credit for choosing real neurological disease, incorporating several legitimate diagnostic concepts, and accurately portraying the idea that body inflammatory response to a dying parasite can contribute significantly to symptoms. Where the episode departs from reality is largely in the speed of the diagnostic process, um, the dramatic sequencing of clues, and some of the decision making that is designed to create suspense rather than reflect standard medical practice.
I feel that's a very honest and fair assessment. Thank you for that perspective. Building on that, my final question to you is that if this patient arrived at your hospital today, what would be the actual diagnostic pathway look like from arrival to her treatment?
Um, so, so the process will be much more systemic. The patient will arrive as a neurological emergency because of the sudden onset of aphasia and collapse. The initial focus will be stabilization, assessment of the airway, breathing, circulation, and rapid neurological evaluation. Stroke will remain a leading concern. Urgent brain imaging will be obtained, typically beginning with a CT scan and often followed by MRI if lesions were identified. At that point, the differential diagnosis would include tumor, abscess, inflammatory disease, vascular pathologies, and parasitic infections. We will obtain a detailed history, including travel history, country of origin, exposure risk, prior seizures, and other relevant epidemiological factors. Laboratory testing will be performed, and if imaging suggests neurocysticercosis, additional studies might be pursued to strengthen diagnostic confidence. Once the diagnosis becomes sufficiently likely, treatment will be individualized based on number, location, and stage of the lesions. And depending on the patient presentation, management will include not only to corticosteroids, anti-seizure medications, and antiparasitic therapies such as albendazole when appropriate. So the key difference from television version is that the diagnostic will emerge from multidisciplinary evidence-based process rather than a series of dramatic insights.
Very well, Dr. Arbab. Your explanation really helps us understand how a case like this is actually approached in a real clinical practice. That brings us to the end of our session. Before we wrap up, I'd like to extend a sincere thank you to Dr. Arbab for joining us today and sharing his insights with us. Dr. Arbab, we truly appreciate the time you have taken to be here and for making this conversation both educational and engaging. It has been a great pleasure having you on Dr. Watches, and we hope to welcome you back for future episodes.
Thank you so much for having me. I love to be back, and it's a great initiative. So, congrats to you guys for making it happen.
Thank you.
Thank you. For our viewers, I'd like to sum up today's discussion. Although we explored the case as presented in the episode of Dr. House, but in reality, diagnosing neurocysticercosis requires careful clinical reasoning, collaboration between multiple specialists, and thoughtful interpretation of imaging and laboratory findings. A huge thank you to Dr. Arbab again for helping us separate the drama from the real world medicine in this case. And thank you to all our viewers for joining us for this first episode of Dr. Watches. If you enjoyed this discussion, stay tuned for future episodes where we will continue exploring how medicine is portrayed on a screen and what really happens behind the scenes. See you all next time. Allah Hafiz.
Allah Hafiz, everyone.
Thank you so much.
Allah Hafiz.